Welcome students. Let's have a glimpse into the classification system of disorders. Two classification systems we will look into. One is DSM and the other is ICD. What is DSM? What is ICD? We'll look into that. Before going into what DSM is and what ICD is, let's talk about a disease or a medical classification or disease or medical coding. This is a process of transforming description of disease or diagnosis and as well as the procedures into universal disease code numbers. The diagnosis and procedures are usually taken from a variety of sources within the physical healthcare system, psychological healthcare records. We can include the transcriptions of the physicians or the therapists, their notes, laboratory results and records, research studies, radiologic results and several other sources. These diagnosis codes, they track diseases and other physical, psychological health conditions, inclusive of various chronic diseases as well. There are procedural codes which track the various interventions which are performed to cure these diseases as well. These diagnosis and procedure codes are used by several aspects of functioning in the governmental and non-governmental sectors, by healthcare providers, by government health programs, by private health insurance companies and several others. A variety of applications in medicine, psychology, public health, medical informatics such as statistical analysis of diseases and therapeutic actions, for reimbursements in certain phases. For example, to process the claims in medical billing based upon the diagnosis and the related groups of diagnosis. Several such applications are used where these diagnosis codes are helpful. Various global disease disorder classification systems are seen across the globe. Some of them I am going to mention to you. One of them is the systematized nomenclature of medicine, SNOMED it is called, and then the remaining two that I am going to mention immediately are what we are concerned with at the moment, the International Classification of Disease or ICD. In short, it is called ICD, and Diagnostic and Statistical Manual of Mental Disorders or DSM. These two are what we are going to deal with today. In addition to this, as I told you, there are several other systems as well, International Classification of Primary Care, ICPC, and then International Classification of Sleep Disorders, ICSD, and several others. Before going into the details of DSM, the present classification system of DSM, remember what I told you, what is DSM? Diagnostic and Statistical Manual of Mental Disorders. Let us go briefly into this history of DSM, the Diagnostic and Statistical Manual of Mental Disorders. This has been used extensively by clinicians and psychiatrists to diagnose psychiatric illnesses from a long time. It's the manual published by American Psychiatric Association which lists all classifications of mental disorders, and the organizing concept of DSM is to assign symptoms to the classification for which they are most relevant. So thus the classificatory system evolves. Each classification contains the threshold criteria for the symptoms it includes, that is the length and the severity both, which are needed for that symptom to qualify to be included in that diagnosis. From time to time, these classification systems are updated in order to incorporate new knowledge. DSM has been enormously helpful in that it created a single language with which we are all able to discuss, collaborate and diagnose the mental disorders across several areas across the globe. Initially, the process of developing a classification system of mental disorders in United States was due to the need for collecting statistical information. The first official attempt was the 1840 census, and 3 years later this led to an official protest stating that there are most glaring and remarkable errors found in the statements pertaining to and respecting what is called nosology. Nosology is the study of classification of diseases. In addition to nosology, there were errors found in prevalence of insanity, blindness, deafness, dumbness, and all these. The protest also pointed out that many African Americans were all marked as insane in many towns, and they were called these statistics essentially useless. Such glaring errors have led to the formation of Association of Medical Superintendents of American Institutions for the Insane way back in 1844, changing its name in 1892 to American Medico-Psychological Association, and in 1921 to the present what is called American Psychiatric Association, or shortly called APA. Hereafter, we will be using the terms DSM and APA. Let us first go into the history of this development of DSM and its versions, several versions. Starting off with DSM 1, way back in 1952 it has been proposed. World War II saw the large scale involvement of US psychiatrists in the selection, processing, assessment and treatment of soldiers. This moved the focus away from mental institutions and traditional clinical perspectives over to normals. A committee was formed to develop a new classification scheme which was called Medical 203. In 1950, the APA committee undertook a review and consultation, and after some revisions within, the first diagnostic and statistical manual of mental disorders, the first DSM, was approved in 1951 and was published in 1952. Then came DSM 2 in 1968. It was published and it listed 182 disorders. Both the DSM 1 and DSM 2 reflected the predominant psychodynamic psychiatry, although they also included biological perspectives and concepts from Kreplin's system of classification. I hope you all students recall what is Kreplin's system of classification. Please recall your personality theories. Symptoms were not specified in detail for specific disorders. Many were seen as reflections of broad underlying conflicts or maladaptive reactions to life problems and patterns, and rooted in distinction between neurosis and psychosis. Sociological, biological knowledge was incorporated in a model that did not emphasize a clear boundary between normality and abnormality. This called for a revision. So DSM 3 came as the revision in 1980. In 1974, the decision to create a new revision of DSM, and the initial impetus was to make DSM nomenclature consistent with international statistical classification of diseases and related health problems. This is where we bring the comparison and collaboration when it came to the development of classificatory systems. What I have just mentioned is about ICD. So this ICD was published by World Health Organization. A key aim was to base this categorization on colloquial English descriptive language, and thus the psychodynamic or physiologic view was abandoned. The first draft of DSM 3 introduced many new categories of disorders while deleting or changing others. A controversy emerged regarding deletion of the concept of neurosis, a mainstream of psychodynamic and psychoanalytic theory and therapy, which was seen as vague and unscientific by the DSM task force. Finally, the version was published in 1980 and DSM 3 was 494 pages and listed 265 diagnostic categories. It rapidly came into widespread international use and has been termed as a revolution or transformation in the field of psychiatry. Then came DSM 3 revised version in 1987. It was published as a revision and categories were renamed and reorganized, and significant changes in the criteria of classification were made. Controversial diagnoses such as premenstrual dysphoric disorder and masochistic personality disorder were discarded. Altogether, this DSM 3R contained 292 diagnoses and was about 567 pages long. Then came DSM 4 in 1994, listing 410 disorders in 886 pages. A major change over here from previous versions was the inclusion of a clinical significance criterion to almost half of all the categories which required symptoms and cause quote-unquote clinically significant distress or impairment in social, occupational and other important areas of functioning. Some personality disorder diagnoses were deleted and they were moved to the appendix in this process. Then came the much popular DSM-4 TR, a text revision. TR is for text revision, and this was published in 2000. The text sections giving extra information in each diagnosis were updated, as were some of the diagnostic codes to maintain consistency. Again with ICD, please remember we are trying to connect DSM again and again with ICD. So this DSM-4 TR had 5-point axial system. The first axis incorporated clinical disorders, where axis 1 all psychological diagnostic categories except mental retardation and personality disorder were included, and the second axis covered personality disorders and intellectual disabilities. Then the remaining axis covered medical, psychosocial, environmental and childhood factors functionally necessary to provide the diagnostic criteria for healthcare assessments. So under axis 3, general medical conditions, acute medical conditions and physical disorders were included. Under axis 4, psychosocial and environmental factors contributing to the disorder were discussed, and axis 5 included global assessment of functioning or child global assessment of functioning, CGAF it was termed as. Now the fresh version, the latest version is DSM-5. It was published on May 18th, 2013. A significant change in this fifth version of DSM is the deletion of the subtypes of schizophrenia. The deletion of the subsets of autistic spectrum disorder was also implemented, and with specifiers with regard to intensity, that is in terms of mild, moderate and severe, has been used. In physical size, this DSM-5 it grew up to 947 pages. There were a total of 541 diagnostic categories. Students, let's have a glance at the differences between DSM-4 TR and DSM-5. Let's have a quick look at this table which is being shown on the slide. The diagnosis in DSM-TR was based on 5 axes, whereas the axes were discarded in DSM-5. Substance related disorders were discussed in DSM-4 TR, while substance related are discussed in DSM-5. Autistic disorder and Asperger's disorder and others were discussed in DSM-4 TR, whereas autistic spectrum disorders were discussed in DSM-5. Disorders usually first diagnosed during infancy, childhood and adolescence were discussed in DSM-4 TR, and neurodevelopmental disorders have been discussed in DSM-5. Attention deficit and HT have been discussed in DSM-4 TR. ADHD with reduced number of symptoms has been discussed in DSM-5 after age 16. Anxiety disorders included obsessive compulsive and post-traumatic stress disorder, whereas in DSM-5 anxiety disorders include GAD, generalized anxiety, phobia, panic disorder, obsessive compulsive and related disorders, trauma and stressor related disorders, which included PTSD as a part of them. Then selective mutism was discussed and classified under the section disorders usually first diagnosed in infancy, childhood and adolescence in DSM-4 TR, whereas when it came to DSM-5 it is classified as anxiety disorder. Panic disorder was specified as with agoraphobia and without agoraphobia in DSM-4 TR, whereas you see the differences in DSM-5 where panic disorder and agoraphobia were included as separate disorders under anxiety disorder. Mood disorders included major depressive and bipolar disorders in DSM-4 TR. Bipolar disorders and related disorders were discussed in DSM-5 along with depressive disorders specially. Schizophrenia and other psychotic disorders with subtypes were discussed in DSM-4 TR. Schizophrenia spectrum and other psychotic disorders were discussed in DSM-5. Feeding and eating disorders of infancy and early childhood were discussed in DSM-4 TR. Eating disorders were discussed in DSM-5. So these were the major changes, and the table which has been demonstrated to you clearly shows how they both differentiated with each other. Now let us go to the other important classificatory system, the ICD, International Classification of Diseases. We are going to term it as ICD from now on. So this is the international standard diagnostic tool for epidemiology, health management and clinical purposes. Its full official name in fact is International Statistical Classification of Diseases and Related Health Problems. Way back in 1860, During the International Statistical Congress, which was held in London, the first model of systemic collection of hospital data was proposed there. Later in 1893, the Bertillon classification of causes of death was introduced at a Congress of International Statistical Institute in Chicago. A number of countries adopted this Bertillon's system, which was based on the principle of distinguishing between general diseases and those localized in a particular organ or anatomical site. Subsequent revisions, adoptions by various countries, and expanding from the original 44 titles to 161 titles has taken place later. 1898, American Public Health Association recommended that the registrars of Canada, Mexico and United States also adopted and recommended revisions of the system every 10 years so that it ensures staying abreast of current medical practice advances. As a result, the first revision took place in 1900 and so on and so forth. The revision which followed contained minor changes till the 6th revision of the classificatory system. With the 6th revision, the classificatory system expanded to 2 volumes. Now, please look at the bulk of the material which is involved in this. The 6th revision included mortality, morbidity concerns, and the title was modified to reflect the changes, that is International Statistical Classification of Diseases, Injuries and Causes of Death. In 1948, the World Health Organization (WHO) assumed responsibility for preparing and publishing the revisions to the ICD every 10 years. WHO sponsored and published the 7th and 8th revisions in 57 and 68 respectively. ICD 9 was approved in 78 and ICD 10 began in 83, and the new revision thereafter of ICD 10 was endorsed by 43rd World Health Assembly in May 1990. In this context, let me tell you, ICD 11 is ready. Very shortly, towards the end of this discussion today, we will also talk about ICD 11 and conclude the session today. So, in the year 1949, when WHO published the 6th revision of International Statistical Classification of Diseases, that is ICD, the exclusive section for mental disorders was included for the first time. So, this is where it becomes significant to us in our present context. So, ICD is currently the most widely used statistical classification system for diseases across the world. In addition, some countries including Australia, Canada and United States have developed their own adaptations of ICD with more procedural codes for classification of operative and diagnostic procedures. As I said, development of ICD began way back in 83 and was endorsed by 43rd World Health Assembly in May 1990. The ICD-10 code sets provide standard coding convention which is flexible, provides unique codes for all substantially different health conditions. It also allows new procedures and diagnoses to be easily incorporated as new codes for both existing and future clinical protocols. ICD-10 CM means clinical modifications and ICD-10 PCS means procedural coding system. These provide specific diagnosis and treatment information that can improve quality measurements and patient safety and the evaluation of medical processes and outcomes. So, it has 21 chapters on the whole and their respective codes are given. The first chapter includes certain infectious and parasitic diseases. Chapter 2, neoplasms. Chapter 3, diseases of the blood and blood forming organs and certain disorders involving immune mechanism. Chapter 4 involves endocrine, nutritional and metabolic diseases, and Chapter 5 is important to us in terms of the mental and behavioral disorders it follows, and the codes are F01 to F99. This is the most important one to us. Chapter 6 contains diseases of nervous system, Chapter 7 contains diseases of eye and adnexa, Chapter 8 contains diseases of ear and mastoid processes, and so on. As we scroll through this whole slide, you can see that out of 21 chapters, there are different chapters which provide us information about different physiological problems. As far as psychological problems are concerned, Chapter 5, which is mental and behavioral disorders, that is what is very important to us, and let us go into the details of understanding this particular system. So, as I said, Chapter 5 contains mental and behavioral disorders with codes F01 to F99. Please note that these codes begin with the letter F. And although there is a scope for up to 7 chapters, most of the disorders in chapter 5 have 4 or 5 total characters. So what is that framework of the F codes that we have talked about? Please look at the table which is being demonstrated on the slide. F01 to 09 include mental disorders due to known physiological conditions. 10 to 19 contain mental and behavioral disorders due to psychoactive substance abuse. 20 to 29 contains schizophrenia, schizotypal, delusional and other non-mood psychotic disorders. 30 to 39 contain mood or affective disorders. 40 to 48 anxiety, dissociative, stress related, somatoform and other non-psychotic mental disorders. 50 to 59 behavioral syndromes associated with physiological disturbances and physical factors. 60 to 69 disorders of adult personality and behavior. 70 to 79 intellectual disabilities. 80 to 89 pervasive and specific developmental disabilities. 90 to 98 behavioral and emotional disorders with onset usually occurring in childhood or adolescence, and 99 belongs to unspecified mental disorders. The purpose of ICD is to serve as an international standard for health information to enable the assessment and monitoring of mortality, morbidity and other relevant parameters related to health. The clinical descriptions and diagnostic guidelines of ICD-10 mental and behavioral disorders provide more specific guidance, stating as a general principle that interference with performance of social roles, like for example family and employment, should not be used as a diagnostic guideline or criterion, according to WHO 1992. In contrast with this that I have just mentioned, DSM-5 in comparison defines a mental disorder, quote unquote, as a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation or behavior that reflects a dysfunction in the physiological, biological or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational or other important activities. An expectable or culturally approved response to a common stress or loss, such as the death of a loved one, is not a mental disorder. Socially deviant behavior and conflicts which are primarily between the individual and the society are not mental disorders unless the deviance and conflict results from a dysfunction in the individual as described just now. So 5 main uses of ICD-10 mental and behavioral disorders classification system can be identified: clinical uses, research uses, teaching uses and training uses, health statistics and public health uses. All these are the advantages of ICD-10. How changes in classification will influence its utility for all these purposes is an important focus of the revision process, hence all these revisions, one after the other and one after the other over a period of time. However, the ICD mental and behavioral disorders classification is applied in a much broader range of settings, like for example in primary, secondary, tertiary, medical settings, in substance abuse settings, rehabilitation centers and several other places, and must be responsive to their needs. So, the mental and behavioral disorders classification are used in a wide variety of research areas, and moreover this ICD-10 mental and behavioral disorders classification is an integral part of training for a wide range of mental health providers and professionals, and it serves as an organizing principle in the education of psychiatrists, psychologists, social workers, mental health nurses and other social, mental health and occupational professionals. It's important in the training of general medical professionals, including physicians and others, used in the training of professionals outside the health setting as well, like those from forensic and educational settings. Let us now conclude this session, students, with some information about ICD-11, which was released on 18th June 2018, in the sense that this is going to be presented in the World Health Assembly in May 2019 for adoption by the member states and will come into effect only from 1st January 2022. So the release is an advance preview that will allow countries to plan how to use this new version prepare translations and train health professionals all over the country. So today, students, we have had a glimpse into different versions of both DSM and ICD classification systems, which are very important in the field of mental health. Thank you.